a talk on examining the angle, which is primarily about gonioscopy, and just a few words at the end about anterior segment OCT and ultrasound by microscopy. I have a lot of interest in gonioscopy, and I'm going to try to throttle back my interest and make this introductory, which is the concept behind this curriculum. I'm going to talk about 5 things, but the most of it will be about examination techniques and grading systems. So let's just talk about principles. The light from the iridocorneal angle undergoes total internal reflection, just like in a fiber optic cable, so that the image from this trabecular meshwork comes up, and where it strikes the air, it reflects back in. Sometimes you'll see drawings where it's reflecting here. That's actually not what happens. The big index of refraction change is between tears and air and reflects back in. And that critical angle is 46 degrees. So if this cornea was super steep, then you would be able to look directly in there. But that doesn't happen very often. This is me trying to photograph the angle of my technician, and I can't see it no matter what I do with the slit lamp. Again, in eyes that have very, very steep corneas, one can see the angle directly, but this is very rare. This is the light coming from the angle and is visible to the observer because the cornea is so steep. And this would be in the case of something like keratoglobus, for example, but that's something that you're not going to see very often in your clinic. So you need to have a way of overcoming total internal reflection. And so that leads us to examination techniques. And there are 2 basic ways that this is done, directly or indirectly. Directly, one puts a domed lens on top of the cornea that changes this angle so that the observer can see right into the angle. So this is now steeper than the critical angle. And there are lots of direct gonioscopy lenses. The prototype is the Kepi lens, but there are some surgical lenses like the Barkan Swan-Jacobs lens. And now in the area of minimally invasive glaucoma surgery, there are lots of new lenses being developed for surgery. The way direct gonioscopy was done originally was to use a steep lens. So here's a Kepi lens. The patient is lying down in the exam room. We bridge between the lens and the cornea with saline, and here is a handheld lens, ceiling mounted, and in the opposite hand is an illumination source, and then one can look directly at the angle. This is useful for children. This is a little sedated baby. I'm using a handheld slit lamp just to look directly at the iridocorneal angle. And you can see that here. You see a Hopstria here as well. There are some real advantages to this technique. There's a panoramic view. There's the ability to change the angle of the view easily. One can put a lens on both eyes to compare the 2 eyes. But it also has some disadvantages. The main one is that it's inconvenient, and anything that's inconvenient isn't used very often. Hard to do indentation, lack of variable magnification. So it's so inconvenient that that's why the Van Herk test was developed. We'll talk about that later in this lecture. But this is something that today is used for exam under anesthesia and for surgery, but not for routine clinic exam. In the clinic, we do indirect gonioscopy, where the light from the angle strikes a mirror and is reflected to the examiner, that is now parallel with the optical axis, as you can see in the sketch. There are 2 main styles of lenses, and we'll talk about both. One is the Goldmann 3-mirror style lens, although many of them have different numbers of mirrors, and the other is a Zeiss style lens, which is a 4-mirror lens. And the thing that differentiates these primarily is the size of the area of contact and whether or not one needs to use a coupling solution to hold the lens against the eye. So the Goldmann style lenses are easy to use, beautiful view. They're great for photography and laser. So if I'm doing a laser procedure in the angle, always use a Goldmann style lens, or many of them that are designed specifically for laser use. Or when I want to do videography for my website on gonioscopy, I would use a Goldmann style lens. But they're less convenient. They can't be used really to do indentation with any sort of power at all. And to me, they really interrupt my clinic flow, because I normally would do gonioscopy before visual fields, before the dilated exam, and any kind of imaging or photography, and the methyl cellulose from the lens really messes with all those things. So I don't use it routinely, but I use them quite often. Of the 3 mirrors in the prototypical Goldmann lens, it's the shortest mirror that points towards the angle. The Zeiss style lenses, unfortunately, the Zeiss lens itself is no longer manufactured, but there are lenses that we'll talk about that are the same idea, are very convenient. It's very fast and easy to look at the whole angle. They are great for indentation gonioscopy. I think they're a little bit harder to master because they require a very light touch. And I think it's annoying for the residents when they watch me do gonioscopy that I always have air flashing underneath these lenses, because it's so easy to accidentally indent the eye. And as a beginning resident, you need to be very careful about that. So if you see corneal folds, that should be only when you're intentionally indenting. It should not be part of your normal exam. So with the Zeiss style lens, one can see all 4 mirrors point to the angle. You can see almost all the angle without moving the lens at all. And if you just rotate it a few degrees, one can see where these junctions are between the mirrors. The 2 main styles are Posner style lens, which has a handle. That's what I use mostly. Or the Sussman style lens, which doesn't have a handle. And so the Sussman lens is great for people with very long arms. So let's talk about examination technique. I'm going to show a series of videos, so these are abbreviated from my gonioscopy webpage. If you want to watch them in greater detail, you certainly can go to gonioscopy.org. So this is the canthal mark on the slit lamp that tells me the patient's lined up and centered so that I have maximum excursion. I'm going to do the exam mostly at 10 or 16x. I don't need to magnify things too much. And I use a short beam of light. So I want a dark room and a short beam of light, because as light floods the pupil, it opens the angle. And you can see that in this gonio video. I have quite a narrow angle, but as I open the light up and shine it into the pupil, it causes the angle to open. So a short beam of light, dark room. I'm not flooding the eye with light, because that's going to change the anatomy. I have the patient comfortable. I tell them that the lens will be close to their eye but won't hurt their eye, and they'll feel it touching their eyelid. You can see that my fingers are braced so I can keep up with her wherever she goes. And my elbow is sitting on the table. As an examiner, if you have shorter arms, you should put your arms on some sort of a block, because if the elbow is waving around, it's just one more thing to worry about. So this is the 4-mirror lens. So this is a Zeiss, again, no longer manufactured. This is the Sussman, also with 4 mirrors, just no handle. And you can see that there are 4 mirrors, all of which point towards the iridocorneal angle. You see that the area of contact is much, much smaller than with a 3-mirror Goldmann style lens. And that's why this lens works so well for indentation and the bigger lenses don't. It also is one of the reasons that you don't really need to have a coupling solution. And now we have this lens on the eye. You can see there's always a little bit of air flashing under there because I don't want to be pushing. And I can see all four quadrants just that quickly, just by going from mirror to mirror. So once one becomes skilled with this lens, it's pretty easy to use and pretty fast. You can see I've braced against her face, so as she moves, I can keep up. And if I want to indent, I just push on the lens. You can see corneal folds there. But indentation is a little bit beyond what we're going to talk about in this lecture, because it's a little bit more advanced. Goldmann style lens, one needs to use a coupling solution, usually methyl cellulose. So it's important that that's done without bubbles. So I can either start the methyl cellulose stream on a tissue and transfer it over, or I can break the tip out and just dump a methyl cellulose into the concavity of this lens. Both of those work pretty well. Patient is anesthetized, of course. She looks up. I put the lens in and rotate the top back. And then I try to hold this lens with 3 fingers so that I can rotate it without using my other hand. My other hand is obviously on the joystick of the slit lamp. But this holding with 3 fingers takes a little bit of practice, so don't worry if that's not easy to do at the beginning. So beautiful view. Very lightly pigmented angle, this very young patient, and iris processes, which are a normal finding. And then I just turn the lens and follow the mirror around with my slit lamp. So it's a beautiful view. I think it's a better view than with the Zeiss, but it's not enough better that I would use it instead of the Zeiss for the reasons we talked about a few minutes ago. So here I am using 3 fingers to rotate this lens. When I'm done, I just push against the globe with my other finger so it breaks the seal. Sometimes these get stuck on pretty securely. I usually look at the inferior angle first. It's the deepest, it's the most pigmented, and it's easiest to use a corneal wedge in the upper and lower mirrors. So this is a corneal wedge showing me Schwalbe line, and that again is a little beyond this talk, but I'll tell you how to find out about that. Then I usually go clockwise to memorize the findings just so I remember where everything is. We're going to go on to talk about grading systems. Grading systems are important to help one document what is being seen in gonioscopy, allowing changes in angle configuration and pigmentation to be recorded, and to permit communication between providers. There are really 2 major grading systems that are in use, the Schaefer and the Spaeth. I'd just like to stop a minute to give some credit to Lee Allen for making this remarkable sketch of the anterior chamber that I use in a lot of my talks now. And my thanks to my daughter Sarah for photoshopping out all of the things that we don't need to describe gonioscopy. So the Schaefer system is based on the angular width. This is the angle. This happens to measure 25 degrees. And usually the measurement is made close to the angle. In this angle, it wouldn't really matter because the iris is fairly flat. So this would be, by the Schaefer system, a grade 3 angle. And you can see here the Schaefer system wide open is grade 4, all the way down to slit. Ours was 25 degrees, so you can see that would fall in this range here. Risk of angle closure is impossible. And really the easiest way to think of the Schaefer system for me is to basically drop the last digit. So this would be a grade 3, somewhere around 30 degrees, somewhere around 40 degrees or more would be grade 4. The Spaeth system is based on 3 things: the level of iris insertion, the angular width, which is the same as the Schaefer system, and then the contour of the iris. This system allows for indentation findings, which is very helpful, and is a system that I use and teach and recommend. So first, the height of the iris insertion. It matters a great deal where the iris is inserting, not just how steeply the iris is inserting. And so you can see here that this is A, it is anterior to Schwalbe line. B would be, and this is an example, and you can tell with a corneal wedge, which again is on the gonioscopy.org website, but we're not really talking about it in this talk much, that this iris is anterior to Schwalbe line. B inserts behind Schwalbe line, which means it's inserting into the trabecular meshwork. And here's an example of an iris that's inserting into the mesh. And then C is that scleral spur. You can see that we use the first letter for all of these, except we're kind of cheating here using the second letter. So A anterior, B behind, C scleral spur. And here's an example. So you can see the full trabecular meshwork, but none of the ciliary body. D would be deep, inserting into the ciliary body face. And you can see here scleral spur, ciliary body face. This is an appearance of many myopic eyes. And then E is extremely deep, where the iris inserts so far back that there's a very broad ciliary body face visible. This is something you would see in a highly myopic eye or an eye with angle recession. And here's an example. Again, scleral spur is here. This is all ciliary body face. So that's the first part of the Spaeth grade, would be a capital letter, A through E. The second is exactly like the Schaefer system. It's an angular width, but rather than giving it a grade, we just use the actual angular width. And the Spaeth system specifies that this is done a third of the way along the length of the iris. So I used my protractor in this case and found that this was 25 degrees. And lastly, we talk about the contour of the iris, what the shape of the iris is. In this case, this is a flat iris, so it gets the letter F. This iris is bowed forward, so it gets the letter B. This is concave, like you would see in pigment dispersion, for example. And just historically, these had different letters, and that's a little bit confusing. In the past, flat was considered regular, or R. Bowed forward was S for steep, and then concave was Q for queer, but these have been changed to F for flat, B bowed forward, C concave. And then in the new system, there's also a P for plateau, where the iris has a relatively flat insertion towards the trabecular meshwork, but then this steep drop off in the periphery because the ciliary body is holding the iris forward. And then we give the grade of angle pigmentation. This is a 0. Pigmented trabecular meshwork should be right here, but there's no pigment there. There's just a trace of pigmentation right here. Grade 1 pigment. Grade 2. 3. And 4, this is the grade 4 pigment that one would see in exfoliation syndrome. And this is a grade 4 pigmentation that one would see in pigmentary glaucoma or pigment dispersion syndrome. So putting these together, this is an unusual angle. There are 2 lines of pigment here, but using corneal wedge, this is the anterior border of the trabecular meshwork. So we would call this a C, because it inserts at the scleral spur. It's 50 degrees wide. I actually measured these with a protractor. And flat, and 3+ pigmentation. So we would call this a C50F3, and that would let whoever's reading the note know exactly what we're seeing in this patient. This patient has a deeper insertion. One can see that it inserts into the ciliary body face. Here's scleral spur, a lot of pigment here. So this is a D because it inserts into the ciliary body face, 50 degrees. Again, this is flat, 4+ pigmentation, D50F4. A picture we've seen before, a painting we've seen before. This is again inserting deep. We can see this is ciliary body face, scleral spur, pigmented trabecular meshwork. Schwalbe line is right here. The iris is flat. And there's 2+ pigmentation. So D45F2. Again, this is a painting we've seen before, an extremely deep insertion. This is all ciliary body face. This is scleral spur, Schwalbe line. So this would be extremely deep insertion, 55 degrees of angular width here, a flat iris, and no pigmentation. So E55F0. This inserts right at the scleral spur. The opening here is quite wide at 50 degrees. It's flat and no pigmentation. So C50F0. This we've seen before as well. This inserts into the ciliary body, into the trabecular meshwork. So we don't even see scleral spur in this. That would make it a B. The angular width is 50 degrees. The iris is flat. There's no pigmentation. So B50F0. This is a patient with pigmentary glaucoma. The insertion here is very deep, E for extremely deep. This is the pigmented meshwork here. Angular width is huge, so 60 degrees or so. It is concave, so this is a C and 4+ pigmentation. So E60C4. One of the nice things about the space system is you can use it to display information from indentation gonioscopy or dynamic gonioscopy. So this is an angle that looks closed. There's no visible trabecular meshwork. So that would be an A. It's in parentheses because it looks like an A, but when I indent, I can see pigmented trabecular meshwork all the way down to but not past the scleral spur, so that would be a C. The angular width here is 15 degrees or so, B for bowed forward, and there's 3+ pigmentation that we can see once we indent. So the space system is a great system. It's a little bit more complex to learn, but it's something that I think is really helpful to use. The Van Herk technique for estimating angular width is useful to confirm what one is seeing on gonioscopy. So for me, sometimes it's difficult to tell whether an angle is closed, and all I'm looking at is the inside of the cornea, or whether it's wide open with no pigmentation. The corneal wedge is a great help, and the Van Herk can also help to tell whether the angle is wide open or closed. So in the Van Herk, and I'll show a movie here in a second, we use the thickness of the cornea as a ruler, and then measure the anterior chamber depth compared with that corneal thickness. So if the anterior chamber is as thick as the cornea or thicker, then that would be a grade 4. And as you can see, if it's a quarter corneal thickness, that's a grade 2. Less than a quarter cornea, that's a grade 1, and so on. So the Van Herk was really important back when there was no indirect gonioscopy. The only kind of gonioscopy was direct. But now that it's so easy to perform gonioscopy, there's not really a role for the Van Herrick as a means of measuring anterior chamber depth. But it is a really good adjunct to use, and I find myself doing the Van Herrick test every time I sit and look at a slit lamp exam. So we're coming in a dark room with a very thin beam of light coming from the temporal side. And I show this because I've had people describe that they're doing the Van Herrick over the pupil. That is not correct. So I bring the beam in until I just barely find the anterior chamber, like that. And then I'm going to use the thickness of my cornea as a ruler. And with that ruler, measure the anterior chamber depth. So this is a young myopic patient, and you can see that her anterior chamber is deeper than the cornea is thick. And so this is a very deep grade 4 angle, not likely to close. This is an eye with angle recession. You can tell it's had trauma because of the defects here in the pupillary sphincter. We make the narrow beam here, measure the corneal thickness like that, and then you can see that this is a very, very deep anterior chamber. Not surprising in angle recession. Just another example here of a very deep anterior chamber. This is a narrow chamber. You can see that the anterior chamber depth is much thinner than the corneal thickness, and that there are actually areas where the iris appears to touch the cornea. So that's the thickness of the cornea, just a very thin anterior chamber here, and areas of touch. So this would be a dangerously narrow angle. And then lastly, this is an eye in which the cornea and the iris are appositional. So again, Van Herrick is an adjunct to and not a replacement for gonioscopy. Techniques for difficult angles. I've mentioned a few times corneal wedge and indentation gonioscopy. These are really very helpful tools to learn. The corneal wedge will help one find Schwalbe line, really helpful in an eye that has no pigmentation or that has too much pigmentation. And indentation gonioscopy is a way of determining whether a closed angle is due to apposition or synechia. It's also a way of identifying plateau iris syndrome. It's beyond the scope of this introductory talk, but if one goes to gonioscopy.org, there's a whole section on techniques for difficult angles, and it will cover that in great depth. Other exam techniques. So gonioscopy is not the only way of looking at the angle. One can use anterior segment OCT, and these techniques are developing over time. You can see plateau iris syndrome here with this steep drop-off in the far periphery, or a closed angle here. This is from the given to me from the Singapore National Eye Center, showing a swept-sourced OCT that actually allows you to look into this angle that's closed. Really beautiful imagery. Another swept source OCT examples of an open angle on the left and a closed angle on the right. And one can see things with ultrasound biomicroscopy. On the left slide, you see an iris cyst, and on the right, pigmentary glaucoma. These technologies are great. I think that they're wonderful adjuncts to gonioscopy. They're going to be tremendously helpful for populations that have a high prevalence of angle closure glaucoma that is undiagnosed, for doing screening techniques. But for the ophthalmologist in his or her clinic, gonioscopy is still a critical technique to know, not just to determine angular width, but to determine pigmentation, neovascularization, all sorts of things that OCT and biomicroscopy can't show you. I do have a website, gonioscopy.org, that has lots of examples of gonioscopy techniques and findings. So an overview of examining the angle. Really something that's hard for first-year residents, but it's a critical tool.